I'm very pleased to be here, especially during May, which is National Hepatitis Awareness Month. So we welcome you on behalf of the Hepatitis B Foundation and our co-hosts, the Asian Association for Asian Pacific Community Health Organizations, or ACTO, and the National Viral Hepatitis Roundtable, or NVHR. Before we start, I just want to invite whoever hasn't had a chance to go and grab a lunch and a water. It's much more pleasant at a lunchtime meeting if you're actually eating lunch. And I would also like to thank and recognize our congressional champions at this time. This includes the Congressional Hepatitis Caucus, which is led by Representatives Reese, May, and Charlie Dent for their longtime commitment to fighting hepatitis B. Congressman Brian Fitzpatrick, who represents the District of Hepatitis B Foundation. Congresswoman Judy Chu and Congresswoman Barbara Lee, and the Congressional Asian Pacific American Caucus. And a special thanks goes out to Congresswoman Lee for getting us through today. And our longtime friend, Senator Macy Dorno, who is a sponsor of the briefing today and has been a longtime champion in support of the cause of hepatitis B. This afternoon, our expert panel of speakers is going to be talking about national elimination targets for hepatitis B, and also a new research agenda that will be used as a roadmap for finding a cure for hepatitis B. We're also going to hear personal stories from people who are going to talk about how hepatitis B has impacted their lives. I'm going to start very briefly with an overview of the burden of hepatitis B in the United States for those who need a refresher. Hepatitis B is the most common serious liver infection. It affects about 240 million people worldwide who are chronically infected with hepatitis B. It is transmitted from direct blood-to-blood transmission. And in the world, hepatitis B is passed on most commonly from mother to child during childbirth. One of the biggest problems is the lack of screening and diagnosis in the world and in the United States. Worldwide, only about 67% of people know that they, in the United States, only about 67% of people know they have it. It's even less worldwide. And unfortunately, if left untreated, about 25% will develop liver cancer or cirrhosis that will ultimately lead to premature death. In the United States, about 2.2 million people are living with chronic hepatitis B infection. But only about 25 to 30% know that they have it, which means that they are at risk for developing cirrhosis and liver cancer and liver failure. We have health disparities that are associated with chronic hep B infection in the U.S. About 50% of the U.S. burden is among Asian American and Pacific Islander communities, who also have a liver cancer risk, that is, liver cancer rates that are about 13 times as high as Caucasians. And liver cancer is one of the deadliest cancers worldwide. And in the United States, liver cancer is the only cancer that continues to rise every single year in both incidence and mortality for both men and women. So it is a big issue. And hepatitis B also disproportionately affects African immigrant communities in the U.S., who make up about 30% of the infection burden. This is what we call the hepatitis B care cascade, or the gradient, which shows you, and you don't really need to read the numbers, all you need to see is the dramatic drop. We have about 2 million people in the U.S. who are infected. Only about 25% get diagnosed. Of that 25%, some are able to get into care. Most have extreme barriers to getting into lineage care and to getting care for their infection. And if you look at the end of the day, less than 5% receive FDA-approved drugs for their hepatitis B infection. So there's a huge drop-off. And if you look, the biggest gap is in screening. There are just very few people in the United States who are at risk for hep B or who are infected know about their infection. And with that, I'm going to turn it over.
Hello, everybody. Thank you for coming. My name is Elizabeth Foxness. I am the Public Policy Director at National Viral Hepatitis Roundtable, NVHR. NVHR is a nonprofit coalition dedicated to ending the hepatitis B and C epidemics in this country. It's my pleasure today to introduce Dr. John Ward. Dr. Ward is the Director of the Division of Viral Hepatitis at the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at the CDC. In this role, Dr. Ward is responsible for planning and directing national and international research, surveillance, and public health programs related to viral hepatitis C work in viral hepatitis. Dr. Ward's experience includes 14 years in the field of HIV/AIDS, conducting early studies of AIDS transmission, natural history and diagnosis, and evaluating prevention measures to protect the blood supply, as well as directing national HIV/AIDS surveillance. It works now? Okay. Dr. Ward has also served as the editor of the Morbidity and Mortality Weekly Report, MMWR, which is the CDC's primary health publication. So please join me in welcoming Dr. Ward.
Thank you very much. Try to not blow you out of the room now that we actually have a microphone to work. Quite the thing. So it's great to be here. I want to thank APCHO, MDHR, and Hep B Foundation for bringing this briefing together. We really have enjoyed a very productive collaboration with those organizations over the years. As with any part of public health, partnerships are critical, and those community partnerships with those three organizations and other organizations like them are very, very important, particularly when you're talking about hepatitis B and the multiple diverse communities that have a health disparity from hepatitis B related liver cancer, liver disease, and other diseases that are caused by this life-threatening condition that's fully preventable through vaccination and fully treatable and controllable through testing and linkage to care and to treatment. Next slide, please. Unfortunately, over the last 5 to 6 years or so, we've done a lot of good work, and I mean we, meaning policymakers, community-based organizations, people in public health, clinicians, etc., in developing very thoughtful plans about what we could do to be more effective in preventing hepatitis B transmission and disease. This is an example of our National Viral Hepatitis Action Plan that's developed by the Department of Health and Human Services in collaboration with all the agencies within HHS, such as CDC and FDA and NIH and others. And there are different aspects of prevention related to hepatitis B that relate to achieving these 4 goals. Next slide, please. Now, we also have a strategic plan that guides our work at CDC in our division of viral hepatitis. And when it comes to the U.S., we have 3 strategic imperatives. We want to vaccinate to protect vulnerable populations from hepatitis B. We want to recognize where transmission is occurring so we can make vaccination available to those populations, particularly adults, as I'll show you in a moment. And then we want to identify people living with chronic hepatitis B and make sure they are linked to care and treatment. And if there's one message I would like to really leave with all of you today is the need to translate scientific advances into public health practice. We have effective treatments now. I think what we're striving to do by this meeting here is really raise awareness about the opportunities to improve those treatments and actually develop cures for hepatitis B. But if those hepatitis B treatments that we have now and ones in the future stay on the shelf and aren't used, they don't help anyone. And that's why you have to have good programs that link communities in need with scientific advances. So you need scientific translation as you move into scientific discovery and into implementation. Next slide. Now, the cornerstone of hepatitis B prevention in the United States and indeed around the world is hepatitis B vaccination, beginning at birth. As was already mentioned, people who get infected early in life are at the highest risk of remaining infected for life. And then over time, that virus attacks the liver, leading to liver failure and liver cancer. Vaccination can prevent about over 90% of those transmissions. And so we have had a very well-developed immunization strategy in the United States that begins with vaccination of infants immediately after birth, completing the 3-dose series through early childhood, identifying children and adolescents who may have missed vaccination earlier to get them vaccinated, and then vaccinate at-risk adults. We do a great job of vaccinating infants. We do an okay job of vaccinating newborns. So we have a situation where probably about 800 infants continue to get infected with hepatitis B because they don't get the interventions right after birth. And we can do a better job of that because about 25% of them will go on and develop liver cancer if they're not tested and treated. And then we have a real problem with adult vaccination. Next slide, please. As you can see in this bar graph, for older people over the age of 19 and for certain risk populations that induce diabetes, the proportion of adults who could benefit from vaccination who are receiving it is very, very low. And we can do a much better job of adult vaccination and prevent transmission among adults. Now, we started routine infant immunization in the early 1990s, so typically people in their early 20s and younger are fully vaccinated, so you rarely get transmission in those age groups. But these adult populations older than that are the ones at risk. Next slide, please. And that's illustrated by the line graph on your right. You see we've had a progressive decline in the number of new hepatitis B infections from year to year, except that we've had a pivot, and we've actually had a 20% increase in new infections among adults in 2015, the last year that data were available. And that reflects the low adult vaccination coverage I just showed you. In a national strategy that was just released by the National Academies of Science, Engineering, and Medicine, really highlight this as a big gap in prevention that we can do a great deal more to close and prevent these transmissions. Sherry already highlighted some of these statistics on the left. The number of people living with hepatitis B is at least 850,000. Other models put that up much higher. About 1,700 people die every year from hepatitis B. That makes it about the third or fourth leading cause of infectious disease mortality of all the infections reported to CDC on an annual basis. And we have interventions that can make a difference with that. Next slide, please. Now, the reason hepatitis B transmission is going up is because of the relationship with the opioid epidemic. That we've had an explosion of increasing in drug use, particularly opioids, heroin, prescription opioids. A large number of those persons are injecting those medications and doing that in an unsafe way that leads to blood-to-blood exposures and transmission of hepatitis B. And we know that can be prevented by Hep B vaccination, but they are not receiving that intervention, even though studies have shown that it's really cost-saving to the country to vaccinate people with this type of risk. So this is a key area that we can do a much better job of than we're doing currently. Next slide, please. Now, to get a handle on this association between hepatitis and the opioid epidemic, CDC recently directed our surveillance dollars to the areas of the country where transmission is happening at the highest rates, and those are the states shown in green. That's true for hepatitis B and hepatitis C. And indeed, we now are giving money, and this just happened on May 1st, to the states that report over 3/4 of all the new hepatitis B cases. And we hope that this will help us better identify these high-risk populations and help direct prevention resources such as vaccination to them. Next slide, please. Now, the other aspect of hepatitis B that's important is the health disparity caused by this infection. Now, Asian Americans in particular have a high prevalence of hepatitis B, but it's also true for other people born in other countries, such as countries of Africa. And that's because vaccination has only begun more recently there, and because of this high risk of chronic infection after you become infected as children, people are migrating after they have become infected, and now they're at risk of developing these life-threatening liver diseases after they have arrived in the U.S. And so liver cancer rates are much higher for Asian Americans. Hepatitis B prevalence is much higher for Asian Americans and persons born in African countries as well. And so we recommend testing for hepatitis B for those populations. And why is the testing important? Because treatment makes a difference. Treatment lowers your viral load, lowers your risk of cirrhosis, lowers your risk of liver cancer. We're going to talk about how those treatments can be improved, but we have some treatments now that can make a difference. Next slide, please. So getting back to this translation, this linkage need between effective treatments and communities in need, we have a number of activities underway. We've developed a hepatitis B professional education training program for clinicians, and we've developed a public education programs targeting communities at highest risk and seeking to develop those materials in languages of their countries of birth. Next slide, please. And we want to send a message that hepatitis B testing is critical, particularly to think about populations born in other countries. People come with different understandings of our health system. I can't understand why that is. It's such a simple system to understand. And so they really don't know really even how to access these services sometimes, or they're not even the concept of taking action to prevent disease is something new for their culture. And so that community outreach and education is very, very important to let them know that they can take action to protect their health and the health of their loved ones, particularly family members. Next slide, please. Over the last several years, we've done a number of studies of this outreach to communities and linking communities to testing, care, and treatment. And as you can see there by these high proportions, we were very successful in getting people to receive information and to be referred for medical care, but actually getting that individual into that doctor's office was not as successful. So, next slide, please. The next set of studies, we really look at a number of different strategies to see how we continue to be successful in getting people tested and referred for care, but then also getting the care. And as you can see there in that third bar, we were much more successful, and we identified a number of strategies that are shown there on the left that helped make that connection more successful. And so we call this our toolkit for getting people tested and linked to care. So we have evidence-based strategies, when applied, can really make a difference in people's lives at a personal level, and then obviously help us at a public health level reduce transmission and morbidity and mortality. Next slide. I'll go back one, please. So these are our 3 priorities for us at CDC, and they're really reflected in this national strategy, as I've already mentioned, recently released by the national academies, where they really set ambitious targets for eliminating hepatitis B. They spent about 2 years looking at evidence in front of an expert panel of people from different backgrounds to really see what's possible for the United States. Next slide, please. And they really determined that setting elimination goals was realistic for the United States. And they thought that with full implementation of testing and linkage to care, you could reduce hepatitis B mortality by 50%. By 2030, you could eliminate hepatitis B transmission among young people through vaccination-based strategies. And they put out a number of different recommendations related to hepatitis B testing, care, and treatment, and improving vaccination that if fully implemented, the National Academies believe that elimination is achievable. Next slide, please. And they believe that, I think they, because of this call to action, that I really think is truly a call to action. I know it is for me, and I hope it can be for you, that most of the barriers to preventing and treating viral hepatitis could be seen as a consequence of another more basic problem, that viral hepatitis is not a public priority in the United States. So the barriers we're facing is not really a function solely of the virus or some other more difficult barrier, but really just a barrier in priority setting and capacity building. And that this was an explicit call to action that the time is now right for this priority setting to change, and that the committee really wants these new elimination strategies to be achieved with the implementation of the recommendations that they put forward. And I agree that hepatitis B elimination is achievable. We have the capacity, we have the know-how, and now we need the capacity to make that possible. Thank you very much.
Thank you, Dr. Ward. I would now like to introduce Alan Brownstein. For 40 years, Alan has combined his business and strategic planning skills and expertise in public health programs and policy to provide leadership in developing and growing health organizations and shaping health policy and regulations in the U.S. Alan serves on the Hepatitis B Foundation board and is our vice president for public policy, where he manages the Hepatitis B Cure campaign. And previously, he served as president and CEO of the American Liver Foundation.
Thank you, everyone. Well, I am really proud to be here today to be the first one to present the public presentation of the Hepatitis B Foundation's Roadmap for a Cure, Priority Areas for Chronic Hepatitis B and Liver Cancer Research. This is one of two papers that have been produced for publication, and we are awaiting word on publication, so it is not in your packet. The second paper is a shorter, more focused in a particular area of hepatitis B research called A Research Agenda for Curing Hepatitis B Infection. So since you do not have either one of those papers, we have provided for you an overview of these two papers in which we have consolidated the contents of those two papers, and we have rewritten them at what I call the Scientific American Light version. So this could be pretty much understood by the educated non-scientist. That overview is in your packet. Now, talking about overviews, what I'm going to attempt to do in the next 9 minutes is give you an overview of the overview. And the next slide, please. The first part of this is the case for a cure. Why we must have a cure for hepatitis B now, but not just must, but the reasons why. First, you heard Dr. Cohn give an excellent presentation of the human burden of hepatitis B in terms of morbidity and mortality in the United States and around the world. Second, you heard Dr. Ward present the scientific consensus that hepatitis B can be eliminated by 2030 from a number of prestigious bodies that believe this is achievable. The next area is that we have not just are we looking for the health outcomes, we're also looking for the economic outcomes. As you can see, the cost of hepatitis B is enormous. Just the charges for a liver transplant it exceeds $739,000 based on 2014 data from UNOS. For the use of FDA-approved drugs, the range is between $8,400 and way over $16,000 every year. And for liver cancer, that is well over $46,000 a year. And sadly, it's used for, on the average, for 5 years, because that's the survival rate for people once they're diagnosed with liver cancer. But that amounts to a staggering $230,000 over a 5-year period. So the cost of treating hepatitis B needs to be addressed. There's also, we see that there's a superb infrastructure at NIH, in NIAID, NIDDK, and the National Cancer Institute, which has the capacity in helping us conquer hepatitis B and liver disease. And another compelling reason for a cure is that hepatitis C is cured. So now there could be a real focus on hepatitis B. And in fact, that focus is increasing right now as we are seeing increased interest on the part of the new drug discovery companies making increasing investments in hepatitis B, and we need to push that along. I noticed that in Dr. Ward's presentation, it was noted in one of the slides that hepatitis B is important, but an underappreciated disease. I'll say amen to that. And in fact, I've said on a number of occasions that hepatitis B, that's really the wrong name for this disease. It should be called non-A, non-C hepatitis, if you will. So, anyway, moving along. I'd like to go to the next slide, and that is that what the Hepatitis B Foundation did under the lead of our president, Dr. Timothy Block, is that he created a virtual workshop where he surveyed 35 of some of the top scientists and clinicians working on hepatitis B. And his goal was to reach a consensus. Fat chance that he would achieve that goal. But he did. He did achieve that goal. And he asked them to come up with a list of priority questions, that are scientific questions that need to be answered if we are really to tackle hepatitis B and cure it. So what he got from these 35 scientists were the most important scientific questions. And then from there, we further analyzed their response, and we identified what needs to be done, how long it will take, and how much it will cost. Next slide, please. The priority scientific questions, the details provided in the overview that you have. But virology is a major focus, and many of you have not heard of cccDNA. cccDNA is one of the primary targets that were identified, and that's why that's in bold. And that's because, very often when people have treatment and then their viral levels get very low or below detection, and you cease treatment, the virus rebounds. And the connection to why it rebounds is in this cccDNA. So this is seen as being a priority target for research. There are other areas that I've listed, but in the interest of time, I'm going to skip through these, and there's some fairly reasonable explanations in your packet. But the other one is that every now and then you hear about hepatitis D virus. And I just want to make sure everyone in this room understands that we are not changing our name to the Hepatitis D Foundation. We have the Hepatitis B Foundation, but hepatitis D is important because when there is the presence of hepatitis D, the aggressive nature of on the disease is far, far greater. So, eliminating hepatitis D is a very important strategy in our efforts to conquer hepatitis B scientifically. Then, of course, there are other scientific questions. Immunology, everyone knows that many people get hepatitis B, but well over 90% resolve the virus, naturally through our immune systems. But this is not so with an important segment of people who develop chronic hepatitis B where it's not resolved. So that's why we need to unravel the mysteries of the immune system. There are a number of other reasons that I will not go into detail, not for lack of time, but for lack of my own knowledge. So, moving ahead, clearly we need to look at viral therapeutics. We need to come up with better therapeutic agents to conquer hepatitis B. And then, of course, the consequences of hepatitis B. Liver cancer is something that we heard how much that has grown and expanded in staggering terms, as well as cirrhosis. I'll get into that a little bit more a little later, but we need to improve our ability to identify liver cancer. Early diagnosis is very important, and we need to work on that. We are working on that. And then there are a number of what I am calling combined approaches that include better measuring instruments for conducting research, having better defined clinical endpoints, and I will mention that with that in regard, we've been meeting with the Food and Drug Administration to try to figure out better ways of identifying surrogate measures for endpoints that would be conducted during research in evaluating new therapeutic agents for hepatitis B. So, and then of course we need clinical trials. We need to look at clinical trials. The model that I see is the model, the AIDS clinical trial group at NIAID. If we could come up with something that would be attached to that, or a hepatitis B clinical trial group, that would be great. And one thing that I love about the AIDS clinical trial group at NIAID is that there are international sites. For us to aggregate enough patients on the quick, it would be not just getting some sites here in the United States, it would be important to get sites in China and Vietnam and the Philippines and other places where the endemicity of hepatitis B is significant, and where we know that there are clinicians who are capable of running these trials. So those are the key scientific questions. So that's I am really impressed with what Tim was able to accomplish in getting people to focus on that. Now, we need to look at what needs to be done, which is the next slide. And what we did is we analyzed these research priorities. And then, looking at these research priorities, we then broke them down into discrete scientific projects. And we came up with 140 projects. Then we took each of these projects and we aligned them with existing funding mechanisms at NIH. So that's what needs to be done. And then on the next slide, we had to figure out how long it would take. So we took 140 of these, and there's sequential necessity that had to be considered. In other words, what gets to be, the building blocks we looked at this like a business plan. How are we going to conquer hepatitis B? So we had to do certain things in a certain order, and it made sense to do certain things first. So we arrayed them, and we figured that if there is full NIH support that we're proposing here, in 6 years, we would be able to come up with the science to cure hepatitis B. And from there, we've had to say, okay, so how much is this going to cost? And the number I'm going to throw out is going to seem like a big number, but in terms of things, it really is not. We figured that an additional $39 million per year is needed over the next 6 years to get to that point. So we have this plan would cost a total of $232 million through 2023. Now, the next steps that we see to cure hepatitis B is to increase support for the roadmap for the cure, and that is the $39 million a year, additional funding. Then we need to develop a trans-NIH hepatitis B and liver cancer research action plan. We would love it for NIH to take our research agenda and rip it up and come up with their own. It'll obviously it'll include 90% of what we have. But we want NIH to take ownership of it and to take accountability for moving forward so that we really get from point A to point B, and that is a cure for hepatitis B. And then what we need is once that research action plan is in place, we need to get some targeted hepatitis B and liver cancer RFPs issued by NIH. And then we need to expand the clinical trials network, as I described before. And then from there, we're only fooling ourselves if we think that's going to be the cure, if we develop all the science. We need to attract private investment so that we can get new drugs to market. We need to develop the right partnerships, public and private partnerships, because it's really the private sector that is going to bring new drugs to the market. And moving to the next slide is the gradient that you saw from Dr. Cohen earlier. And this gradient is incredibly important because if you go to the next slide, and this speaks to what Dr. Cohen and Dr. Ward talked about, and that is the small number of people who have been diagnosed with chronic hepatitis B. And if we leave it as it is now, if you look at the top, because I misplaced my pointer, and so if anyone sees it, oh, it is. By magic, I have it. Okay, so here, if you see that, it's not, no, it's not, okay, forget that. If you see, I have this complicated at the top, D, C, and T, and that's diagnosis, care, and treatment in very broad terms. So right now, with the current situation as described by Dr. Ward, we now, through 2030, we will have 206,000 cases of cirrhosis. We will have 120,000 cases of liver cancer, and we will have 188,000 deaths. If we just increase, according to the Healthy America 2020 campaign of HHS, if we increase the numbers of those diagnosed from 35% to 66%, we will have a reduction, a rather small reduction, but from 203,000 cases of cirrhosis, liver cancer from 120 down to almost 117,000 cases, and the number of deaths down from 188 to 179,000. So that speaks to Dr. Ward's point about that, well, yeah, people are diagnosed, but they're not getting sustained treatment as is necessary. Then if you look at the WHO 2030 projection, we see that there, the assumption is 90% are diagnosed, 90% are in care, and 80% are getting treated. That's getting close to what Dr. Ward was shooting for, and what we at the Hepatitis B Foundation want. And here you see a substantial decrease of where cirrhosis is reduced from 206,000 to 114,000, liver cancer from 120 to 78,000, and deaths from 188,000 to 93,000. And that's really, if we don't succeed, that is really terrible. And that is why we need a cure. We need not just the reasonable treatments that we have now, we need a cure. And I'm going to go back to hepatitis C. There's interferon and all kinds of combination therapies that existed. But many people were not treated and were not cured of hepatitis C. But when we had Sovaldi and new drug discovery, we were able to cure. We were able to get millions of people to sign up for the cure. So when you have a solid cure that people can count on, that gives everyone the motivation. The patients, the families, the public health professionals, the motivation to get people into treatment. So that is why we need a cure. And if we don't succeed, I've painted the picture of what's going to happen in the future, and we can prevent this by coming up with a cure plus public health. And the next slide shows why we must succeed. These are people who are directly affected by hepatitis B as part of our storytelling project. And, you know, I presented some staggering statistics, but the human face of what hepatitis B means is critical. And I'm going to close with what I consider, and what we consider, to be the formula for success. And that is science-driven advocacy equals a cure. And that's why I'm so happy that you're here today, and hopefully we can join forces in getting a real cure for hepatitis B. Thank you.
I'm the Director of Policy and Advocacy for APSHO, the Association of Asian Pacific Community Health Organizations. We represent 32 community health centers, including 27 federally qualified health centers in 13 states, and our health centers serve over 500,000 patients. In Asian American, Native Hawaiian, and Pacific Islander health centers, the rates of hepatitis B are 4 times that of the average health center. So hepatitis B is an issue that is very dear to our hearts, and it's why we're here in DC advocating for a cure. So today I'm here to introduce Congresswoman Grace Meng. She is serving her 3rd term in the United States House of Representatives. She represents the 6th Congressional District of New York, which encompasses the New York City borough of Queens, including West, Central, and Northeast Queens. And one of our APSHO members and Happy United partners is within her district, which is the Charles B. Wang Community Health Center. Congresswoman Meng is the first Asian American member of Congress from New York State, and the only Congress member of Asian descent in the Northeast. I worked with her office when I lived in New York City, and she helped to highlight many issues for AAPIs, including in hepatitis B and data disaggregation when she was a state assembly member. So we're very thankful to have her here today. Thank you very much.
Hi, good afternoon, everyone. I apologize for rushing. I have 6.5 minutes left before votes end, so I need to speak fast, and please don't hesitate to reach out to our office after this. But I really want to thank the Hepatitis B Foundation for inviting me here today. And before I begin, I just want to acknowledge a good friend of ours, a role model for so many of us, Congressman Mike Honda, who during his 8 terms in Congress, he led the fight against hepatitis B. He founded the Congressional Hepatitis Caucus and promoted hepatitis screening and prevention programs in Congress and throughout the country. So just wanted to, say that I am trying to follow his footsteps and committed to working with you and partnering with you in combating hepatitis B, and will do my best to be a champion in this fight. I hope that together we can make hepatitis B history in this next decade. I'm not going to tell you, you all know more about hepatitis B than me, but worldwide there are 250 million people chronically infected with 800,000 related deaths. During this briefing, today's briefing alone, over 1,000 will die. In my speech alone, a few hundred will die. And in the United States, there are 2 million chronically infected with hepatitis B, which will result in 188,000 HBV-related deaths by 2030. But this is an issue that is not only important to us nationwide, but as was mentioned, locally, right in Queens and New York City. It's a huge health issue in my district, in Queens, New York, one of the most diverse districts in the country, a district where about 40% of the constituents are of Asian AAPI background. And hepatitis B, as you know, disproportionately affects Asian Americans, and so it's a huge concern in my district. I want to again acknowledge the famous Charles B. Wang Community Health Center, providing really comprehensive health service. They do like everything, we just call them for everything. Even if it's not health related, honestly. But just helping tens of thousands of families in our district. And today's event is so important. I'm really happy to join you in this launch. I'm not going to finish the rest of my speech because I'm going to miss votes, but don't hesitate to reach out to us. We want to be a partner. We want to continue Congressman Honda's great work and to partner with you. So thank you so much.
Okay, hello everyone.
My name is Rhea Aracho. I'm the Program and Policy Coordinator for the Hepatitis B Foundation. And today I have the privilege of introducing you to our last two speakers, who are both featured in the Hepatitis B Foundation's recently launched Just B campaign. Just B is a national campaign to put a human face on hepatitis B using personal stories. We partnered with an organization called Story Center to produce a series of short videos that capture these personal stories of people living with or who have been affected by hepatitis B. The goals of this campaign are to increase awareness about hepatitis B and its role in causing liver failure and liver cancer, to decrease stigma and discrimination that's associated with hepatitis B, to promote testing, vaccination, and linkage to care, and to advocate for people affected by the disease. We were able to bring together a diverse group of storytellers to participate in this campaign. From people from across the U.S., we had storytellers from age 19 to 75 who represent a very wide variety of perspectives and experiences with Hep B. We have patients, family members, adoptive parents of kids with hepatitis B, and several others. So each story reflects a unique personal experience and an important message about hepatitis B. And today we actually have, we get to hear two of those stories. So we have Ben and Boomy. I'm going to introduce Ben Lee first. He's from Northern Virginia. He is currently getting his master's in urban planning from Virginia Tech. I'm going to go over and play his video real quick. It's about 2.5 minutes, and then we're going to give him some time to speak.
Sitting in the waiting room, I was still sweating. I'd almost missed the walk-in hours at the community clinic. With all we know about being safe, about HIV and STDs, it felt normal to get checked. I liked going to the community clinic. It was just a mile off campus, and I liked the sense of being anonymous. I had a family doctor, actually. He's an older gentleman, Vietnamese as well, and a family friend. But being gay, I just wasn't comfortable seeing him. That afternoon, I went in to get tested for STDs and came out knowing I have hepatitis B. But I wasn't surprised. I knew my 3 older brothers had it. They'd been encouraging me for a while to look into my status, but I thought, I feel fine, I'm young, I feel healthy. Now knowing I had the virus, I still felt healthy, so I put off any follow-up. It took several years. It just so happened my roommate was a nurse. One day we were talking and he suggested I go get PrEP as an extra precaution. It's a pill you take that prevents HIV infection even if you're exposed. My roommate set up the appointment so I wouldn't put it off. I went in to get evaluated for safe sex meds, and I left knowing my hepatitis B viral load was very high. I started treatment. Not a moment too soon, my doctor said. Sometimes people ask me, was it hard finding out you have a virus? Being the son of refugees is a big part of who I am. I feel like any adversity I might face in my life pales in comparison to what my parents have experienced to get me here. Other people ask, why is it important to talk about hepatitis B? I went to get tested in the first place, and I knew the value of communicating with sexual partners because of all the advocacy around HIV and STDs. But I would pause before I tell them I live with hepatitis B. And they always pause before asking, what is that? And then I begin to explain. Just be advocate.
So thank you for inviting me to speak today. I'll keep it short. Bumi has a wonderful story as well. And I guess I just want to say that, in my video, I mentioned, being gay and Asian American, it added this extra hurdle into seeking treatment. That in addition to having hepatitis B, I didn't want to seek help and treatment. I kind of just wanted to deal with it myself. And I was fortunate in a lot of, in many senses. And I can see, along the way where others might not have sought treatment, whether they're, because of the stigma of having the disease, because they are LGBT, because, they don't want to tell their family, because they don't want to talk to a doctor, because they just aren't comfortable. With my own fortune, I hope that I can lend my voice, so that others, where I didn't have the education and awareness, that others will have that, and will, reach out and seek help, and seek treatment, and hopefully one day, with this, working with the Hepatitis B Foundation, we can advocate for more funding, that we can, find a cure for hepatitis B. Thank you.
Thank you, Ben. And our last speaker is Bumi Daramaja. She lives in Maryland, and she works as a pharmacist. So I'm going to play her video now and allow her a few minutes to speak as well.
Nobody wanted to talk about it. His friend, who's a well-respected doctor, knew. But it wasn't something to be shared. It was viewed as taboo. A few years after our dad passed, when I was back home in Nigeria, I requested for his death certificate. That's when I found out for sure he had liver cancer. Before he died, my mom complained, "Your dad's not eating." By the time he decided to actually go for a checkup, he never came out of the hospital. He was gone, just like that. We were supposed to be a perfect family that never had health problems, never had to take medicines. How could this happen? No one wanted me to say anything about it. I felt like I was a bomb, about to explode, and I was capping it in a bottle. I felt helpless. I also started thinking, I wonder who's next? I came to the US when I was 18. I know that some people in Nigeria, especially in the villages, believe there is an evil force that people can use against each other, leading to illness. In my family, we were not exposed to this kind of thinking. Still, sometimes I wonder if it's true. Maybe this is why people don't believe my father's cancer was caused by a virus, hepatitis B. Stigma is everywhere, rooted in this old belief. People don't think about the facts of how the virus is transmitted. They are afraid to even touch someone who has it. Some people in my community know they were infected with hepatitis B, but blood tests show their immune system fought it off, and they were fine. Others find out they have chronic hepatitis B infection, but do not understand the need for follow-up. In Nigeria, many people don't even want to get tested because treatment is either not available or costs too much money. they say, what's the point? In the US, the services are here. And I want to make sure that people of African origin know there are resources. I want to end this silence. Just be open.
Thank everybody for being here today to hear and listen to my story and an issue that is very dear to my heart. Hepatitis B has been destroying so many lives around the world. My dad was never sick, never a smoker, never a drinker, never had any reason to take any medication. And he was a very happy man. When I was in college, we heard about hepatitis B, and it was nothing much to think about. I remember my mom complained that he wasn't eating well and refused to go for a checkup. Well, by the time he decided to go, he didn't come back home. He was in the hospital. He died 3 weeks later. My dad had 3 children. Myself, my sister who's here today, and my brother. I thought that my dad died of prostate cancer until much later that I found out it was liver cancer, Hep2. It hurts because this is a preventable and treatable disease that we shouldn't have died from. There are so many people worldwide who have this disease, hepatitis B, but they are not aware of it, or because of stigma, they can't come out, or the testing is just too expensive and treatment is too expensive. I've been silent for too long. I was watching the YouTube one day to watch about documentaries on hepatitis B, and I realized not one African documentary out there, not one African talking about it. And I decided I have to do something. This has to be my call. I have to let people know what is happening out there. I have to encourage people to come out and talk about it so they can seek treatment. I have to be the voice for African descent, people from African descent living in this country, because even if you talk to any of them, sharing those, they tell you, no, nothing is wrong. Even some of them know. And some don't even want to bother to find out because they can't afford the treatment. There are research companies out there, Bloomberg Institute, NIH, doing research to find cure. They're working tirelessly to find cure for this disease. That's why I'm asking Congress if they can support the funding for this disease to find a cure and more treatment so that we can help people out there live long lives, and they don't have to be afraid. We have, like you said, we have a cure for hepatitis B, was none for hepatitis B. And sometimes I wonder why. Maybe there's not enough focus on it, or maybe they don't think it's that much as important as hepatitis C. But it's a very, very dangerous disease that Congress really needs to do something about. America is a country where great things happen, where if we are determined to do something, we do it. And other countries look up to us here in this country to do great things, which we do, if we really want to. The world is becoming a melting pot, where one problem that affects a country affects us all. Hepatitis B creeps into your family, destroys that prosperous, happy family. It happened to mine. My dad was 65 years old when he died, and he shouldn't have. And to make life even worse, this horrible disease crept in and took my brother's life at the age of 35. Just imagine if you have a family of 4, 5, 6, and you're just watching them drop dead just like that. Just go. And there's nothing you can do about it. That's what's happening to so many thousands of families out there. And there's no cure. They can't even go for treatment because they cannot afford it. Just think, what would you do? What would you do? How far will you go to find help for people? How far will you go? Just think. I just beg and hope Congress will do something about this. Thank you.
Thank you so much, Ben and Bumi, for sharing your stories with us today. At this time, I would like to open it up for questions of our speakers on the panel.
My name is Andrew Lionel, and I'm the Chief Scientific Officer of a company called Replicol. And there's two of us here that represent these industries. What are we trying to do? We're trying to help all of the patients in the world get control over their disease. And I wanted to give you some perspective. I was really struck by the emotion and the drive. The Hepatitis B Foundation is really one of the leaders in this field, as you probably know very well. But let me give you some perspective. Everybody here has seen the movie A Field of Dreams, or knows this movie, Kevin Costner movie. There's a great saying in that movie, which is, if you build it, they will come. What is it? It is the market. And who are they? It is the large pharmaceutical companies of the world. When mountains have to be moved, and hepatitis C is a great example of this. When mountains have to be moved, there's no faster way to galvanize people together to find solutions to problems if they can see that there's a way to get a return on their investment. And that's just the way life is. So we've got the field here, right? Think about hepatitis C. Why do we have a cure? We have a cure because there's a test. We can test for the levels of the RNA in your blood for hepatitis C, and that test is accepted as a way to say you have control of your virus. So these companies have a way actually to get in with regulators and say, how can we prove that we're going to be better than what all the other drugs are, right? So we have this kind of test for hepatitis B. What is this test called? It's called the surface antigen test. How do we know this? We know that every patient on the planet who has hepatitis B, who has gotten rid of the surface antigen and kept that protein away on treatment, those patients are what we call functionally controlled. They don't need treatment anymore. Their livers get better. One of the challenges we have in this field is how do we galvanize us and our players in the industry to come together as a team to combine all the different elements, and there are many here. There are many companies that are working on trying to attack this disease by many different ways. And what's the biggest problem we have? First, the FDA is worldwide respected, and rightly so. Right, so we all have to make sure that we get here. And we have the FDA agreeing with what we're trying to do because it's recognized around the world. So there's a challenge we have here, okay, which is the way to measure the change in that protein. It's called the quantitative surface antigen test. Everybody in this room should remember this. It's very important. This is a test which is approved for monitoring hepatitis B infection everywhere in the world except for where? Here, in the United States. And when we're trying to bring combinations, this is a political statement, but it's very important. I feel very strongly about this. If you want companies, small companies like mine, large pharmaceutical companies to engage and spend these huge dollars, we need a way that we can show regulators that what we're doing is making a difference. And that test, if it was approved, would allow all these different companies to get together during the clinical development of drugs to be able to show regulators, aha, we're making a difference, we're moving forward, we're moving forward, we're moving forward. So this is a huge impediment. It's something we really have to consider. I know that Timothy Block has approached Congress and lobbied them on this particular issue. And kudos to him and Robert Gish for doing that difficult challenge. This is an essential issue that we have to think about. We have the tests. We have the ability to move mountains. We just need to be able to get that done. So that would be my comment. Thank you.
Thank you for your presentation and for sharing your stories. I was wondering what is being done in Congress or by the administration or NIH to address hepatitis B?
Yeah, over the last year, as we've been talking about hepatitis B with members of the Congress, Tim and Joan have made 20 visits to the Hill, to the Senate and to the House, just this past February and March. And we have excellent counsel with Mike Hall and Allison Lewis in helping us on the Hill, and also our DC staff working in coordination with that. And there have been actually very good responses, very positive response to the research agenda and as it was being developed, even to the extent that we actually have new funding to the tune of $1.3 million from the Department of Defense, if you could believe that. That's great. We have $9 million of new funding from the National Cancer Institute just over the last few months for cancer research, in keeping with our evolving research agenda. And we have heard that there's an additional $10 million in RFPs coming out from NCI, although that's not confirmed yet. So the point is that someone just said, build it and they will come. The thing is, even before we built it, the fact that we were advertising that we were building it, they're beginning to come. So I'm just saying that, you know, this is really, I'm very optimistic about this. And I'll just comment and just explain to you the difference between an optimist and a pessimist. It's really quite simple. The pessimist has better data. However, I will remain an optimist on this because we have darn good data in supporting our research agenda. So that's why I'm optimistic.
My name is Nick Walsh. I work for the Pan American Health Organization, WHO, World Health Organization, Regional Office for the Americas. So the United States is a member state, of course, and all of the countries of the world are meeting this week in Geneva at the World Health Assembly. Last year there was the global hepatitis strategy that was signed on by all member states, including the United States. My question is, what can we as the WHO do to support you in your quest? for funding, for highlighting this issue of getting at hepatitis.
John, you want to tackle that one?
Well, because you know this from Charles Gore, what we want is to get hepatitis B back up on the top 10 disease list. WHO used to have hepatitis B included as one of their top 10 disease targets. It got removed with the vaccine, but the problem is, and Dr. Ward can attest to this, the vaccine is very useful, but it is still not reducing the overall. We still have over 250 million lives. If there's any way you have it in there.
Hit the out and flagship.
Get it back up, elevate its, or put viral hepatitis at least. Put viral hepatitis, which is, this is I think what the WHO has done, though, is really shown a spotlight on the problem of viral hepatitis with their global strategy. So I know that you guys have been working hard to get viral hepatitis. But that's the specific thing we want.
My name is Randy Heyer, and I'm a former WHO staff member. Mentioned even, yesterday, a new director general was elected. And I think one thing, if the WHO Geneva hears from the regions that you think it's a priority, that may be an opportunity to get onto the agenda of the new administration. They're formulating that right now. So this is the opportunity. And certainly AMRO or America, the Regional Office of America has a big burden, but there are other regional offices that have tremendous burdens. I'm sorry. Wherever. Africa, it's a big deal. But for all regional offices, really. And work with your colleagues. And that's what's.
Yeah, I was just going to say the same thing. I looked at the backgrounds of the three candidates. I don't know who was selected, but of the three candidates I saw, there was not a particular background around viral hepatitis or anything. And with Dr. Chen leaving and being from China, I mean, now for us to get, in whatever way we can think about getting on the agenda early on, I totally agree with your point, and that would be important.
Thank you for asking.
Well, it's kind of ironic that I stand up to speak in support of what this is all about. I had no idea, and I'm still a little bit confused and lost about all these H. A, B, C, D's I'm not sure. But what's unique about Lumi's story, I'm also an African by birth, from Liberia, and I represent the Immigrant Americans Institute and Foundation. So is it possible to get funding here in DC? Yes. There are thousands of Africans that live in the DMV. And certainly we want to be there to support you and you as well. My wife, I'm married to an Asian, so she talks about this all the time. And I have no idea what she's talking about. It sounds like some vegetable, always making vegetables. But I think the best solution to what you want to do, Tony, is to run for Congress yourself. Your story is so compelling. The only person that can tell this story as well as you and as Bing are the both of you. And so asking people here that won't connect, the messenger, both of you. So you should consider it. I mean, there were people, we can help you make this happen. Your way to the United States and to the rest of the world. So if you want to do it, we'll be happy to help you. And we'll be happy to work with you guys to see if we can get some funding for you as well.
I think there's a lot of people ready to work on your campaign. Any other questions at this time?
You got to run, go vote.